comprehensive primary care CPC initiative worked to improve care, improve health, and lower costs for patients and their families in the primary care setting. Nearly 500 primary care practices and more than 2,000 practitioners were enrolled in CPC from 2012 to 2016. The CPC initiative focused on 5 functions of primary care: access and continuity, planned care and population health, risk-stratified care management, patient and caregiver engagement, and coordination of care across the medical neighborhood. This on-demand learning series explores how CPC practices implemented strategies designed to strengthen primary care.
A primary care group, physician-owned. We're independent, non-hospital affiliated. We have actually 5 practices throughout the Southeast Portland metro area, 3 of which are CPC participants. What I'll do today is share with you how our care coordination team is structured, how our workflow is driven by the American Academy of Family Practitioner risk stratification methodology, and sort of how we've used our care coordination outreach, that workflow in particular, to reduce readmissions, reduce high ED utilization. Again, we use the AAFP risk stratification tool to drive our workflow with the care coordination team. That tool is structured, it's a 1 through 6 system, with 1 being very low risk and 6 being end-of-life type hospice-appropriate situations. So because our care coordination team, there's only 5 of them and close to 30,000 patients, we have decided to have our care coordinators work with the highest risk patients to account for the limited resources that we have. So they automatically do outreach to level 5 and 6 patients, and they'll work with level 4 patients at the provider's express request, or if upon reviewing their huddle sheets in the morning, they see a patient who could probably benefit from care coordination outreach. We know it's very important to reach out to our lower risk patients too, but seeing as that's not a possibility, to have our 5 wonderful care coordinators call 30,000 people, we were lucky enough to start a separate department called the Panel Coordination Department. And through the use of a system called EDI, it's the Emergency Department Information Exchange, which allows, primary care arm of that is actually called pre-manage. It allows us to see 100% of our patients' visits at hospitals and emergency rooms in Washington State as well as all of Oregon. So when our lower risk patients present at the hospital or ED, our Panel Coordination Department feeds that information into a dialer, and they're contacted and asked if they'd like to schedule an appointment with their provider. Additionally, our higher risk patients are contacted personally, because that personal touch is very important, by our care coordination team. This here is just kind of a dummy account to show how we go about risk stratifying our patients. Initially, before our EHR system, and we use a Greenway product called Entergy, we didn't have such a simple process here. We used to have to add the risk stratification level to the problem list, which was several clicks. Additionally, that information was accessible to the patients through the online patient portal. So it resulted in a lot of questions like, what does risk level 5 mean? And so it led to a lot of uncomfortable situations, and it's really kind of behind-the-scenes stuff. It's really a method to drive our workflow and not necessarily something that needs to be shared with the patient. So since that time, we put an expectation for our providers that they should have at least 75% of their patients risk stratified. our entire practice, we have about 90 to 95% of our patients risk stratified. If a provider falls below that 75% threshold, then in addition to being shamed by their peers, they are also provided with a report of their unstratified patients who either they or in teaming up with their nursing staff would risk stratify. Our care coordinators also have the ability to adjust the risk stratification level. So if they've encountered a patient who had a lot of hospital visits or isn't managing their chronic condition well, they have the permission to increase the risk level, and they will inform the provider that they've done so, but they don't have to ask for permission. But because the risk stratification is such an important part of our workflow, before they reduce a risk level or graduate a patient out of care coordination, they first need to get permission from the provider. And what you see here is what the provider would click, a line that says care program. This window comes up, and you see the fun little 1 through 6. That's the AAFP methodology that I mentioned earlier, and they would grade the patient situation using that. So it's just a 1, 2, 3 clicks for them. So not a whole lot of complaints there. And so here is the second part of that piece where you see that the patient is graded. So blue bear here is a risk level 5. And what that means is, let's say, for instance, our patient here had presented to the emergency department and they've discharged. Through the system I mentioned earlier, Premanage, they built dashboards for each of our care coordinators so they can see when this patient has hit the hospital and when they've discharged. And that risk level means that our care coordinator, Kate, or any of the team would reach out to this patient and ask them a series of questions about their medications, if they understand the instructions that they were given from the emergency department, and schedule a follow-up appointment with the provider. During the course of that conversation, if they find that there is a need for further care coordination involvement, they will enroll the patient into our care coordination plan, onboard them, as we call it, and that will trigger the risk stratification-driven outreach. So Kate or a member of our team, depending on who this person's provider would be, would, since they are level 5, they would check in with them telephonically monthly, try to schedule them with their providers at the very least quarterly or as needed, and update their care plan here in our EHR quarterly as well. The patient's a level 4 patient. We check in with them a little less frequently. That would be telephonically every 3 months, care plan updated every 6 months or as needed, and try to get them in to see their doctor twice a year or as needed. Towards the end of 2014, beginning of 2015, a health plan that most of our patients that we see are on, I should say, reached out to us and they said, "What are you guys doing over there?" Which is usually not a good thing to hear. But in this instance, they wanted to talk to us about how we were able to successfully reduce our readmission rate by 19%. We shared with them our risk stratification-driven workflow, our ability to reach out to our patients in real time, 24 to 48 hours upon discharge from the hospital or ED, and they were thrilled to hear it and have asked us to share that with other practices to see their members. But yeah, we're absolutely thrilled.
For more information and resources, visit the Comprehensive Primary Care Initiative webpage. Go to innovation.cms.gov and search for the CPC Innovation Model. This has been a production of TMF Health Quality Institute.